most families are faced with somebody who survives an injury in recovering them and if you're without a family, having to recover with no assistance at all, except find other survivors who have successfully recovered. And that's why the Trauma Survivor Network has worked and has been a factor for many, many survivors to learn how to recover from the mental aspects of recovery, which are very difficult to overcome.
Hey, this is Brent Myers. I'm the Chief Medical Officer here at ESO. I'm an emergency and EMS physician by background and training, and I'm sitting between two pillars of the trauma community. So it's an interesting spot to be in, and we'll moderate this as we go along. But I'll let them introduce themselves.
I'm Glen Tinkoff. I'm a vice chair of surgery and chief of trauma and acute care surgery at University Hospitals in Cleveland, Ohio. And I'm also the president of the American Trauma Society.
And my name is Samir Fakhry. I'm a longtime trauma surgeon, a variety of academic level 1 trauma centers around the country. Currently, I'm the vice president running the Center for Trauma and Acute Care Surgery Research in Nashville for the HCA system. And I'm also a clinical professor of surgery at George Washington University in Washington, D.C.
Great.
Thank you for inviting us.
Yeah, no, great. And thank you all for being here. We're here at WAVE on the first day. And one of the things that I wanted to talk to you all about is we just released our trauma index. And one of the findings in there that new this year, we're measuring the mechanism of injury that activates the trauma system. And as it turns out in 2024, 55% of the activations for trauma in the United States were for ground level falls. And those disproportionately occur in people over 65. So there's a lot of activation going on. What do we think about that? And how can we as a trauma system, from dispatch to EMS to emergency medicine to trauma, address that issue? What are some of the concerns that you have around where we are with that?
Well, my major concern is we have a gravitational field, and it's not going to go away. And we have an aging population. That's not going away. So it's only going to be more numerous and more difficult to care for this population, which most of us, I know when Samir and I trained, this was not a population we were attracted to the field for. I shouldn't, based on my training, be managing the medical comorbidities of this population, and I have to now have a workforce that does that. And it's really transformed what a trauma service looks like in my hospital and really as a reviewer of trauma centers in many of hospitals. It's just a different workforce that are managing these patients, including an extended workforce of advanced practice providers.
Yeah, I agree with Glenn. I mean, first thing to recognize, of course, is geriatric trauma is important because hopefully, if we're lucky, all of us will need it one day in terms of we're going to trip and fall and we're going to end up going to the hospital. And you hope that the team that meets us there is the right team, depending on, what's going on. But I think we need to stop for a second and remember, as you were saying, Glenn, the original concepts of the trauma activation criteria and how we approached an incoming trauma patient were developed at a time when most of the trauma we did was motor vehicle crashes and penetrating trauma, and in predominantly younger individuals. The average age of patients in our registry when I was getting started was a lot lower than the average registry age right now. And that is, partially the population aging, but partially that we have begun to absorb more of these patients into the trauma care pathway, because there are some data that suggests that we're a bit more efficient at getting these patients taken care of, predominantly hip fractures and some TBI and root fractures. But I think what we're seeing here is that as we have shifted the population of patients coming into us from mostly younger to now mostly older, as you pointed out, we haven't really adapted the system that cares for them as quickly as perhaps we should have. In other words, we still use what our criteria heavily weighted to high velocity trauma, complex trauma. When you look at older individuals, and I'm going to call them older adults, geriatric trauma patients, most of the injuries they sustain are low velocity injuries like ground level falls. We're not seeing a lot of penetrating trauma in the older individuals. We're not seeing a lot of high speed motor vehicle crashes. Older folks tend not to go out driving Saturday night and trying to race down the highway. They tend not to be involved in violent events. So I wonder if it's not time for us to begin thinking about reorganizing how we approach the injured older adult, both in the field, during transport, and upon arrival to the trauma center. As Dr. Tinkoff pointed out, we've had to completely reorganize the trauma care model to take care of comorbidities, medical problems, not so much trauma issues, but more issues that are encountered when patients are older. So I think it's probably time to think about this in a slightly different way than we have in the past. Instead of looking only at, say, vital signs, only at mechanism of injury, maybe we should consider other variables that perhaps research will show us affect the outcome of a patient. Because activating the trauma team for a patient who's hemodynamically stable, has a slightly low Glasgow, maybe at 14, fell down, broke their hip, and maybe is slightly concussed, is not the same as activating for a gunshot wound or high-speed motor vehicle crash with multiple injuries. And the data support that. The average ISS for the geriatric trauma patient is 9 or less across the board in every study that's ever been published. And the proportion of patients with really serious life-threatening trauma who are older than 65 is lower by about half compared to younger patients. So again, I wonder if these are two different subsets that need slightly different approaches, recognizing, of course, the unstable patient still needs a trauma activation. The low Glasgow Coma scale still needs an activation. The occasional penetrating trauma involved still needs it. But this is a different group of patients, and I think perhaps it's time to look at them that way.
So we were talking earlier, and one of the things that we love to do at ESO is integrate the data, right, from dispatch all the way through the end of the registry. So if we think about the EMS practitioner today, on almost every ambulance that you will get on, there will be some version of the red and yellow ACS, either electronically or literally right on the side of the rig for somebody to look down and say, I'm activating based on red criteria number 1 of a systolic less than 90, whatever it may be. And then that gets translated to an internal activation criteria that may be the full activation or a partial activation or what have you, depending on the way the trauma centers are set up. How can we bring those two things together, to your point, so that if we want to redo this, it's a seamless opportunity, right? We can say red criteria number 4 is no good anymore, take it off, and the internal activation follows. What's missing for us to be able to do that today?
The data and understanding. Well, going back to those 2011 field triage criteria, and then the update, I think, is 2021. Those are based on data, the best available data at the time, and they have been, they have been recognized as predicting those type of patients, those that do need full activations. The partial activation, the yellows, are the ones that have to be modified. And if you look at hospital triage criteria, what happens when they get into the hospital, that list of yellow is actually expanded, and it's problematic because you're robbing the workforce of tasks they have to do in the ICU, tasks they have to do in the operating room, tasks they have to do on the floor taking care of patients. And they're and the ED has to change its response. So you're bringing people in to evaluate, Dr. Fakhry was saying, evaluate a patient that really only needs imaging after a triage evaluation. And it can be done by a nurse and in an APP, and move the patient to imaging to get a diagnosis. Now you know where to put the patient. But we give a whole team, and we scare the hell out of the patient, especially a grandma in her 80s who just took her, we undressed her in front of 10 people. And then psychologically hurt.
Yeah, no, I agree. And I had two things to remember. The red criteria, in other words, if a patient is physiologically abnormal, that patient, it doesn't matter what age they are, it doesn't matter what mechanism. If you have a Glasgow Coma score, that's low, and when you talk about what that means too, or a systolic blood pressure that's low, admittedly with the older patients, maybe we need to look at that a little bit because they tend to run higher blood pressures. But if you have physiologic derangement or you have an airway emergency, it doesn't really matter what age you are. I don't think that's the problem. So I agree completely with Dr. Tinkoff. It's more the partial activations or the yellow criteria. And the other point that I'd like to add to what you said is repeated evaluation along the way matters. So when you first see the patient in the field, you may get one set of vital signs and one set of assessments. Along the way, that may change. The physiology and the biology of injury is such that it does change. Plus, you're intervening, you're doing things to help the patient. I wonder if more frequent evaluations and more frequent communication between the field and the hospital could also help us refine the process. Because I couldn't agree more. Historically, we've thought that having the entire trauma team respond is really important. And I think we're increasingly seeing that, no, we don't necessarily need that entire team, especially when that team's trying to do other things in the hospital. So the consequences of having the team come when they're not really needed to do life-saving interventions, essentially over triage, is really consequential for other tasks in the hospital. Plus, there are data that show that these repeated activations for pretty low-level trauma tend to depress the morale of the team, the residents, the APPs, the attendings, because you're coming, you're ready to do life-saving stuff, and it turns out it's really not so much a life-saving event. It's more about expediting care. So these are all consequential things that matter. The resource utilization, the impact on the team, the busyness factor goes up. I can tell you residents historically in surgery programs have always said, we don't want to be babysitters. We don't want to be taking care of patients where we're not operating. Now, of course, that's a very one-sided, rather selfish perspective, if you don't mind me saying so. But in a way, they're right, is that when you have valuable resources, whether in the field, in the emergency department, or in the trauma team, you really need to be careful how you allocate those. We're getting busier. We don't have as many people. And the demands on us, the expectations, have increased from documentation to speaking with families, which is very important, to taking care of other, not just the injury, but the many other things that the patients bring. It's a lot of work for everyone involved, from the scene all the way to discharge. So I think it behooves us to be more efficient and be more thoughtful about where we allocate the resources and which resource is really needed. So yes, let's come down and help. Let's participate. But do we really need 7, 8, 9, 10 people, or pulling the attending out of the ICU or the operating room worse yet sometimes? So I think that's really worth looking at. And there's no question, it's the data that should drive it.
That was very well said.
Thank you. You too.
The issue of a lot of this is when these triage criteria, it got embedded within at that time, I think it was the Green Book, the Resources for Optimal Care of the Injured Patient. They're field triage criteria, and they were because the triage criteria based in that document were really 6 criteria, all pretty much physiologic or some injury related. But the fact is that those were hard and fast. This weighted in the field for 30% over triage, and that was a guess. Mm-hmm. But to get 5% under triage, because under triage is life-threatening. That didn't mean that the same thing, once hospitalized, once in the emergency department in the trauma bay, that you're going to use that same criteria, except those 6. That's how it evolved. Unfortunately, what evolved was a much different pattern of expanding that yellow criteria and still calling down a portion of the team that still was vital to other services upstairs. And that's what you're talking about. And putting a trauma attending, and pulling them out of what they're doing, because we're usually covering 2 to 3 services, and they be in the operating room, having to come down and man that kind of and participate in that kind of event. It's problematic, often at night, and difficult to enter.
Basically is that, not only is it disruptive upstairs, it's disruptive in the emergency department. These activations will take an emergency attending 30, 45 minutes away from a very busy department. We already have, wall time problems with EMS. So it's a flow problem all the way around for the activation. A little pivot around resource utilization to think about the more acute patient and this notion of pre-hospital whole blood. This has clearly been demonstrated in the military environment. Right, the evidence there is overwhelming, and now we've got civilian data. So now we're at the tricky part, not dissimilar to our trauma activation criteria. The evidence is clear. Now we have to do the implementation science, and how do we make it happen in the field in a way that's consistent with the evidence? So a couple of things to reflect upon. One of those is making sure we have sufficient supplies, and how do we balance the blood supply? That's one topic. But the other one is, in our data today, out of hospital whole blood is administered for medical patients about 25% of the time. And there is no evidence today to support the use of whole blood in the out hospital environment for medical patients. So we've got two problems with the supply question, right? One is just, can we up the part stock enough to get the ambulances stabbed and make sure that blood rotates back in and doesn't get lost due to waste? But then secondarily, how do we think about utilization, because the tools on the shelf and somebody's going to use it?
That's a great lead into that topic. Yeah, I agree that it has over about 8 years now with the military experience, followed by a really effective work in the civilian area, has shown that whole blood, those who receive whole blood, the earlier they receive it, do better. And we're talking about survival. And, I was surprised by it, having, trained in the Shire's years where we gave crystalloid before. We have to prove they needed any blood product before we did that, which was harmful, honestly. But when you think about it, whole blood is the mother's milk of trauma. I mean, that's basically, you shed it, you need it back. And you need it back as fresh and as good as it can be. And getting it as early as possible. And that's what it shows. So it never surprised me when it's come back. And not in parts of the blood product, as we often give it. Or the 1-to-1-to-1 has done very well. But I think we have to be very careful with delivering it, especially in the field. And I didn't know that percentage you had just gave about, it's given to medical patients, 55%, usually 35%. That's interesting in itself. You certainly in EMS, you want something that's going to work, and this works and helps us with the remainder of the resuscitation when they come in, and actually probably reduces blood product utilization afterwards once we get the bleeding stopped. So this has been a long lead into, are they bleeding? That's what we need to know. And how are we defining? Now, if we see the bleeding and hopefully stop it, we know they're bleeding and they're a good candidate. But, intracorporeal bleeding, chest, torso, is more difficult to define. It's how you define that. And obviously there's physiologic parameters to that. And I think those are the subjects that are really problematic in the field.
Yeah, and to add on to that, I think from the medical perspective and talking with individuals, they see a volume of blood that is shocking, but it's not acute bleeding, right? It's been GI bleed has been oozing for days and days and days, and then you get, a large amount of blood presenting externally that's not fresh blood. But as someone that doesn't see that all the time, you come up on that, you see the same volume, you see the trauma patient, all of a sudden you're administering whole blood. So it's an interesting.
It's also mixed with I caught that. So
Right.
I don't. The data isn't there to support that.
That's right.
And that's the problem.
I wonder if you all thought about the other questions that have come up. So as we've adopted whole blood as a primary intervention for bleeding for the patient in hemorrhagic shock, I'm trying to sort out in my mind some of the challenges that the folks in the field are facing. The logistical challenges, for one, right? Because maintaining a supply of whole blood in your ambulances and in your helicopters is not straightforward or easy or inexpensive. Especially overall, we have a shortage of blood in this country, and maintaining a resource that's not used all the time. I mean, it'll be used, but it's not going to be used frequently enough so it can be replaced on a regular basis. It's basic. It comes up and a patient will need it, and then for a while you don't need it. So for me, there's a challenge of the logistics of how to maintain it, how to acquire it, keep it, and use it. Then there's this other sort of a trifurcation here, where we know that getting the patient quickly to the trauma center for source control is very important. So the time element's important. So taking time to set up a blood transfusion is going to compete with that. So hopefully we don't use up the time. We do it during transport, for example. And then there's the issue of, in somebody who doesn't have source control, Dr. Maddox taught us a long time ago that you don't want to raise the blood pressure too much because it just makes them bleed more. And so whole blood transfusion helps, but how much of it? And quantitating the bleeding inside the chest or abdomen is no easy task, even for experts. Even when you're looking at it, it's not always easy to figure out exactly how much is there. So I think we have some work to do. I think we need to understand where the optimal use of blood should be. A 10-minute short transport in an urban environment? Probably not. I don't see that as a big use. A 35-minute flight from one center to another? Yeah, that seems like a more, adequate use. And then what about in between? And what are the limits, So I think there's a lot of work to do still, even though the data have emerged about the utility of blood. Give them blood, give them TXA, get their airway managed, get them to the trauma center. I mean, it's no easy task. So there's a lot to talk about and unpack, as they say there. So I think somehow or another, we continue to have a lot of research that needs to be done. Over the years, we've done a lot of research, and yet we just uncover more work that needs to be done. And I think the focus has shifted to the field on this particular subject quite a bit. So the opportunities to do meaningful research that informs our understanding of how to resuscitate, how much to resuscitate, and whether or not to resuscitate versus rapidly transport. I think we still have work to do there.
Yeah, I think there's a couple of things that are coming very quickly. One of those is there is a best practice emerging around the blood supply question. And it seems to be more or less a 2-week field rotation. And if the blood hasn't been used in 2 weeks, it returns to the blood bank. We still get to 2 weeks of life, so it doesn't, we don't waste the blood in that way. That's still a logistical challenge, even though it sounds simple to your point. I think that's difficult. The other question that we have found consistently in the data is that there is a 10 to 12 point improvement in mean arterial pressure from the administration of pre-hospital blood. Interestingly, some of the regions that starting mean arterial pressure is not all that bad, right? And so your question is a good one, which is at what point do you have a gunshot wound to the chest and somebody's an extremis, and do we wait on the big mean arterial pressure to fall on the field or not? It's a really interesting time.
Well, in extremis, it's pretty much clear to me you should give it.
Right.
I would do everything. People who are not unresponsive with low blood pressures, that's a relatively straightforward scenario for me. It's the ones you're talking about, the ones that are right there at the edge. They're sort of marginal, and your transport time is 20, 30 minutes. Do you do it? Do you not? I don't know that we have the answer quite yet. And by the way, for better or for worse, we're not all exactly the same. And some of us live at a blood pressure that's lower, and others live at a blood pressure that's higher. Older adults, generally speaking, need a higher blood pressure to perfuse their brain compared to younger adults. So a lot of work that needs to be done there, and which is great. I mean, the opportunity to generate new knowledge and impact the care of patients is, I think most of us would love to be involved with and continue to be involved with, because it's what makes the work meaningful and gives us the opportunity to look forward to better results in the future.
But we have a blood supply that's threatened. And so, I mean, in this discussion, we have to talk about a citizen's obligation to provide their blood product to the blood supply. We should all, if you saw the crowd in there at the opening, all of us should be donating blood.
And many people do. I mean, there's a disproportionate number of healthcare workers who contribute blood compared to the general population. There are certain segments of our population tend to donate more, but you're right. I mean, you could help not just in this particular field of pre-hospital transfusion, but there's so many other areas where you could help by improving the availability of blood. So go out and donate blood.
Yeah, no, I think that, and I want to kind of pivot to the last topic, and then we'll have some closing remarks. But there's a really interesting and alarming phenomenon that we are seeing in our data, and it will be presented in research in a couple of weeks. So hopefully this won't be put out in public before we present it. But we helped the state do a research project, and for the ages between 12 and 17, 40% of EMS responses were for mental health crisis. And we don't know for sure the trends because we haven't had the data to be able to measure it all that accurately for long. But there is this common understanding that maybe this is a result of COVID years, lack of socialization, and this movement into the non-interactive social media space. We are also seeing a tremendous increase in gun violence in that same age group. And that paper is published and is out. What is our obligation as a community, as dispatchers and EMTs and firefighters and emergency medicine and trauma, to help improve this situation? What can we do? What should we be doing? Because the call to alarm is there now. The data are in front of us. And we've got to figure out a way to make this different.
Yeah, I was talking about advocacy is very important relative to our to survivors and their families. I was also talking about the comprehensive nature of recovery is not part of what the hospitalization is about. Most families are faced with somebody who survives an injury in recovering them, and if you're without a family, having to recover with no assistance at all, except to find other survivors who have successfully recovered. And that's why the Trauma Survivor Network has worked and has been a factor for many, many survivors to learn how to recover from the mental aspects of recovery, which are very difficult to overcome, especially post-traumatic stress disorder.
Yeah, I think the whole issue of prevention for children in the teen years, especially, is really important because they're one of the groups that can't advocate for themselves, right? I mean, they don't have as big a say as other groups, and there are many groups of people like that. But for teenagers, for younger adults, I think it's really important to note that there's been a shift in both the quantitative and the qualitative nature of what we're seeing going on. There are more diagnoses of mental health. There are more instances of suicide. There's more exposure to things like social media and the stressors that can bring to a young person. There's probably other exposures, whether environmental or societal, that the problems that I used to worry about for the 15 to 20-year-old have now shifted to an earlier age. And it's the 10 to 15-year-old that I'm thinking is the more affected. And I think it's part of the growth of our society and the way it's grown, that younger people are being exposed at an earlier age to some of the stresses and some of the challenges and some of the difficult, whether it's environmental, whether it's societal, whether it's bullying at school, whether it's problems in the home. And then you wrap into that the gun violence and their access to guns. And yes, you are going to see more suicides. You are going to see more children requiring medical care and transport to hospitals and interventions that I don't think we would have thought of having at this very young age a generation or two ago. So yes, I do think this is a group that deserves our attention because they can't really advocate for themselves. They don't really have the political leverage. They don't have the impact. And gosh, what group could be more important to our future, as a society, as a family, this is where we should be spending a lot of our time. And I'm hoping that we will not forget how important that is in an age where it seems like the resources are becoming more scarce and the attention is being driven elsewhere. We have some very serious problems, not just in the older age group patients we talked about, but also in these very young people. And so I think we need a very, very careful reassessment of what we can do and how to do it. And research has to be part of that.
Yeah, thought came to mind. We're a country in which the leading cause of death in children is firearm violence, gunshot wounds.
Mm-hmm.
What does that say about our nation?
Yeah. So,
no other nation, no under-industrialized nation has that moniker. It's a sad thing to recognize, and I agree. It's having access, and we're not saying all this is acts of violence. It's acts of suicide is
most of the time,
yeah. And having an unsecured firearm in the home is dangerous with a child affected, as you said, in those age groups.
Well, I hope a year from now we'll be together having this conversation and things will have improved. What is the one thing we as a integrated data company could offer over the next year that would have the biggest impact to the trauma system?
It's a great question. Data systems registries, having been on the National Trauma Data Bank Committee when it was formed back in the 1990s, had a floppy disks, and we're at a point where the nimbleness of these data systems and linking it to AI will be transformative. It's hard to predict when you're still, and it's hard to know how to answer that question when you're still in the game. But it informs us. And the faster we can have that information, we can apply it and we can change. And we've seen the rapidity of change in trauma care. So it is so rapid now that really just look at the whole blood discussion. We came from an age when that was really never even thought of, that we were ever going to give you cold blood again. And now that's how we're trying to figure out how to give it again. I'll let Dr. Fakhry talk to that as well.
Well, I think to answer your question, I think one of the opportunities that any large successful company that deals with data would have is to make sure first that the quality of the data is high, which I know yours is. So absolutely continue doing that. Second is to link data along the continuum of care and provide an opportunity to view data from the beginning of an episode to the end of it. And the end of it is not discharge from the hospital, by the way, right? It's subsequently what happens with the patient, especially in their first year. And I think if you're able to provide this sort of longitudinal continuum of care data set it'll really inform how we approach patient care, not just in specific instances, but in how we set priorities, because we do have finite resources. And we talk about things that we find one of my friends, she's a brilliant researcher, used to always say that it's the shiny objects that get people's attention. But the biggest impact may not be to do this or that just because it seems popular or fancy or sexy, as the case may be. But when you have a data set that truly represents the entire episode of care from injury to recovery, you can begin to get a much, much clearer picture of where do you get the most bang for your buck, to use a colloquial term. Where do you get the best return on investment? Which is what we've done in many other fields, right? In business and in trade and all that. But I think that's the opportunity that you have. You're probably ahead of many others where you could say, we have data from very shortly after an injury, all the way through perhaps the discharge. And here are the places where you can make a difference. I think one of the problems we've struggled with over the years is that we've only had segments of this care pathway. And yes, we've learned a lot, and we clearly have come a long way. I mean, I can tell you, even in my career of 30-some years, that I can't disclose the exact number, but it's unbelievable how we've changed and how much we've done better because we've learned, sometimes from our mistakes and sometimes from our successes. But I think that's really your opportunity, and out of any large keeper of data, is make sure you provide a comprehensive, high-quality picture of what's going on, and then make it accessible. Partner with people who want to study this and have the tools, and I know you have some of them. So I'm looking forward to that. Perhaps we can talk some more about it later.
Yeah, I agree with what Dr. Fakhry has said there, and really reiterating that message, and also realizing that it has to be user-friendly, because there'll still be human interface, and how we apply that in the continuum of trauma care. As I stated before, we do not fully recover our patients, and to understand how that recovery and that path to recovery goes is very important. I agree with Dr. Fakhry that longer outcomes are necessary to see if are we really making a difference.
So thank you both for coming here at WAVE in 2025. We look forward to seeing you at WAVE in 2026.
Thank you for having us.
Thank you.